I am Dr. Amit Gupta, Joint Secretary of Diabetes India, and today we are having the final day of the ADA, and it is the day 5 for the last 4 days. It has been a great experience. We learned so many things from all the speakers who have covered almost everything which was discussed at the ADA meeting. And with us today, we have Dr. Bansi Sabu, Secretary of Diabetes India and the Chair of IDF Southeast Asia. He is joining us live from the Maldives Diabetes Society meetings. So welcome, Dr. Bansi Sabu.
Thank you, Amit. So first of all, let me thank all the speakers who agreed to join in last 4 days, even though for their busy schedule. This what we thought of that those who were there in American Diabetic Association meeting, they were trying to get the best of ADA, the snapshots, what has been discussed in ADA. And in last 4 days, we tried to cover as many as topics. We had covered technology, we covered type 1, we tried to cover the obesity, GLP-1, newer drugs, even for prevention also. Today is the last day with the diabetes in women, which is the today's theme. I'm thanking Jaidas for supporting our today event. Again, our partner on webinar and our event partner, RX Event, I'm thanking them. And today we have 3 speakers, Dr. Anuj and Dr. Purvi joining. And till that, I will be asking and discussing with Amit that, what you think that something which was new or a controversial topic which was discussed in pregnancy and diabetes.
So, Bansi sir, before we go on to that, I think there is another important thing which we should discuss in this program. And one thing is that we all have been following ADA standard of care for last 35 years, and both you and me were in that session. And one thing which was highlighted at the ADA was that now we have a lot of evidence, lot of guidelines, and we know what to be done. So more than 95% is now very, very clear that what is to be done. But still, the standard of care is not translating into the standard of practice.
Very true.
So this year, the ADA started on this keynote, and this was the keynote by the ADA's chief advocacy, chief quality officer, and he talked about that now it is the time that we should be not only be thinking of what is to be done, we should also be thinking of how it is to be done. So it is a period of transition from standard of care to standard of practice. So before we go into diabetes and pregnancy, I would like to have your viewpoint on that.
So Amit very rightly said, and we were thinking since years that making guideline or making a paper is a different thing. Making a consensus or a guideline or creating awareness for that guideline, that is the second part of it. But the third, that most important part is executing that guideline at the level of primary care physician. And we are struggling this since years. Even we have made our own RSSDI guideline, you know that. When I was president of RSSDI, we decided that let us try to create district coordinator in each and every district. We have just discussed only about the RSSDI guideline and a case-based discussion that how a guideline, you have now guideline, national guideline. Accordingly, will you able to treat the patient or not? Now, even the government also started getting the guidelines. Today, if you remember that West Bengal had come out with their second chapter of guideline for that, because whatever the drugs which are available in the government setup, how that it should be utilized. So everyone is struggling, and this same thing we learned and listened from American Diabetic Association also. It means the primary care physician of US are also not primarily practicing what is being discussed in guidelines as per ADA. So even they are struggling when everything is insured, third party, they have to justify whatever they have written. So even they are getting difficulty that the guideline which is made with so much science-based, evidence-based, still it is not practiced in the primary care. The same issue we are also having, and internationally everyone. So it is the right time in 2025 we can think of. In idea of International Diabetic Federation had also come out with their guideline in IDF meeting Bangkok. I think it's a time not to create a new guideline, rather than whatever the guideline which is available in your region in Indianized way, how it can be best practice in your clinical practice. And this is also one of the reasons that 2/3 of our diabetic patients are not getting control, because the primary care doctor is not following the guideline. If someone is already with an 9 HbA1c, the insulin initiation to be done, a person with obesity, GLP-1, SGLT2, with established cardiovascular disease, all those things which are discussed is not in practice. We know there are 100,000 primary care to consultant physicians which are practicing diabetes in our country. So I think one of the important reasons why our patients are not getting a good control of diabetes, even though in last 25 years so many new drugs had come, so many CMEs, so many educational programs, national meetings, conferences, and even our annual meeting of Diabetes India, which we are doing also in last 25 years, so many meetings, and RSSDA regional meeting, but still and no, so many newer drugs had come, but still the A1C of the patient is still more than 8.5 average A1C. So I fully agree with you that it's a time that we should try to execute these guidelines in our day-to-day clinical practice. And we should promote these guidelines to our primary care physician that how they should use this guideline in their clinical practice. I think auditing their own cases, seeing their own patients' reports, if they are putting it in electronic medical records, let us see there what is happening to them in last 6 months, in last 1 year, in last 2 years, whatever they have written, is the patient sugar is getting control or not? So these are some of the challenges and issues which are there. I think because of Amit, some network issue, he left. But we are waiting. If Purvi join, then we start the first session. But this is a very important discussion about the guideline. Guideline existence is there, but guideline execution, guideline use in clinical practice is not there most of the time. And that's really a big challenge which we are seeing in our clinical practice. Is Purvi joined? Amit, in between you were disconnected, but I finished with that we should start talking about the guideline execution at primary care level. And I think our next session should be for primary care doctor, that a case-based discussion with international guidelines which are available, IDF, ADA, ESD guideline, even our national guideline, where they are finding difficulty in executing these guidelines in their clinical practice. And the second is, which my thinking is, if you are keeping your electronic medical records properly, see them regularly, what is happening to the patient. Just seeing last before 6 months, HbA1c was 9, and again you are seeing with the HbA1c of 9, it means whatever you have done is not sufficient for the patient.
Point, because most of the time we think EMR is only for record keeping, but EMR can also be one of the great tool for benchmarking also. So you
So
can actually see that how your practice is performing.
exactly. It, actually speaking, my type 1 care improved once I had become the part of International Suite Registry. So in 2013, I was there, and first time I had gone in a SPAD meeting to see what is happening in Suite Registry. And I asked that, can I become outside the European region still? Can I become the part of it? And they had given me, yes, you can be the part of this CP4 registry. And then, I started recruiting all my patients in registry. And within 2 years, what I have seen that, uh, how my patients are doing and whether I can do something more for them to improve. Because I started regularly seeing my patients and I register. Even when I'm not seeing the patients, if I have to publish anything, I have to see my own data. So seeing your own data, you will improve. And that is what I'm saying for every doctor now, that if you keep electronic medical records, not just for the keeping their address and phone number or anthropometric data, try to do put everything regularly. Like, you and me have just written a paper from a HealthFlix data that, hardly few people are actually using urine albumin creatinine ratio. But it may be true also that many of the doctors are not putting the data properly. So maybe in HealthFlix, they are using this as a platform only to use as a prescription software. But if you use it regularly, audit yourself, benchmarking, reviewing your own data, it will improve. You will improve. We all will improve. And that's the only way by which I can see the people will be using. And you will also see that whether you are really using the guideline also in your clinical practice, what you have started a patient. The one very simple example, even in diabetes is a difficult situation, but the guideline is there for lipids. Still after 15, 20 years of statin, all the scientific evidence, what you are seeing, you are not seeing some patients are not prescribed, many patients are prescribed with a low dose, it is not intensified. How many patients are keeping their LDL less than 70? People are not using the combination. And these are all common things, which is much easier than to adjust the doses of oral anti-diabetic or injectable anti-diabetic in compared to that writing a statin. So it's a completely a clinical inertia. Or sometimes we don't explain the patient, even you have written the medication, but after 3 months, 2 months, patient gets his own report and he stops. It's very commonly, he feels that now my cholesterol is normal. The same thing happens sometimes in thyroid medication, they stop. They stop antihypertensive. It means somewhere we are not educating our patient also properly that this is for lifelong therapy. It cannot be used only for a few weeks or few months. It's lifelong therapy. So many challenges are there, and I fully agree with you that just to make a guideline with the experts, they use all scientific evidence and then they write it with so much, hard work. It comes out with in a paper form. And it was when this was discussion was there that first time when ADA has released this guideline, it was 8 pages, and now it is some 180 pages. So now with so much scientific evidence for each and every small things, it has been written in that. But we are not using it in our clinical practice. We mean, I'm talking of from 100,000 physicians who are practicing diabetes, or at least they are prescribing anti-diabetic medication also.
I think, sir, the message is that the guidelines now, most of the guidelines cover everything, and we know what is the standard of care. So it's time that we standard to care apply to our clinical practice. Now, coming back to, sir, your first question, which you talked about diabetes and women and diabetes and pregnancy, what was discussed at the ADA. So let us start this discussion by talking about the diabetes and the G. And you know that in the that can we use CGM in pregnancy for the early detection of the GD or early detection of dysglycemia? If we can do that, then how early one CGM should be applied and what should be the cutoff value for the CGM? I know this is still an area which is debated and there is no clear consensus on that, but I think there was a lot of discussion happening in that area. And also
Technological
the use.
advances were there in pregnancy and diabetes. A lot of technological advancement, and one advancement was using a continuous glucose monitoring for diagnosing dysglycemia, for treating them with lifestyle intensification, when to start insulin, and for all those things were discussed. Today we have our discussion. I think Dr. Purvi, if joined, she can start with the first talk. I mean, anyone from RX event, have you called Dr. Purvi Chawla or Manoj Chawla?
Sir, just a moment. I'm calling.
So, sir, let me ask you, what is, we have discussed that we can use CGM probably at around 8 to 12 weeks of the pregnancy. And if we find there are some spikes which are happening in the CGM, then it can be a good predictor for diagnosis of early dysglycemia in pregnancy. So, how do
At
you
least
see?
for early dysglycemia and lifestyle intervention, it can be a very good choice. So I tell you, Amit, for my practice in my clinical practice, I get a lot of references from the OBGY colleague. But one of my biggest, the referral for is an IVF specialist and a big center. And they almost every day, a one new person or two persons with maybe suspected dysglycemia or an obese person, or because we had given them a clear cut guideline, then above the age of 35, if someone is coming for even pregnancy or planning for IVF. So, even pre pregnancy planning also we see the patient. And I use continuous glucose monitoring for many of them. So I had never used or asked that my, those who are referring patient to me that you do OZTT, for the people. If you feel that these are the high risk people, the best thing to put them on a continuous glucose monitoring to understand the dysglycemia. And first thing, it helps that we can change the nutrition or dietary modification can be done to improve their glycemic control. We try to keep between 80 to 140. That's what the target range. We can keep 70 to 140 or even 63 to 140 because some glucose level down is fine in pregnancy, but that is what we do. But most of them, I try to keep it around 70 to 140. We have pleasure of Dr. Purvi Chawla who joined, and I will request Dr. Amit to introduce her, and she will be talking more about the technological advances in pregnancy and diabetes. Today, our topic of the symposia is mainly with diabetes in women. And she is one of the experts from India to talk on it, and she was right there for all the sessions. So she will bring some new insights and some snapshots of ADA for everyone who joined. Once again, I'm thanking Jaidus for supporting us. Again, our partner, RX Event, for event partner, thanking them, and thousands of the doctors who joined from India with the help of Jaidus for today's seminar. So over to Amit for introducing Dr. Purvi Chawla, and then we can start the session.
So we welcome Dr. Purvi Chawla and for the day 5 of the ADA snapshots. And Dr. Purvi Chawla is a senior diabetologist practicing in Mumbai, and she is part of the National Executive Maharashtra. Sorry, Maharashtra RSSDI executive, and Dr. Purvi is known for many initiatives and work. She has worked for multiple clinical trials, published a lot of papers. She has worked with RSSDI, social media cell member, and the Defeat Diabetes core team. She was part of it. She is also currently the chair of the Diabetes and Women group of the Diabetes India, and is a very active member of the diabetes and a very well-known name in the field of diabetes. So over to you, Dr. Purvi Chawla, and look forward to learning from you in this space, in this particular space of diabetes and technology in women in pregnancy.
Thank you so much, Amit, and a big thank you to and shout out to Dr. Banshi Sabu sir, Dr. S.R. Arvind sir, and of course the entire team of Diabetes India that has organized the snapshots of ADA. This year's ADA was really, I felt, was a game-changing event and a fantastic one, very innovative sessions, and we really enjoyed it as an academic feast. So, my topic today is pregnancy with type 2 diabetes and integrating newer therapies and technology. This particular session was on Sunday of the ADA meeting, and three very riveting uh, speakers were there: Dr. Helen Murphy, Dr. Jacqueline Maya, and Dr. Wendy Bennett. Three really very prestigious names in the field of women or pregnancy with diabetes, and I really enjoyed this session. So let me just present some snapshots from the same. So we know that type 1 diabetes and women are known to have poor pregnancy outcomes, and macrosomia still impacts 60% of the live births with type 1 diabetes. Large for gestational age actually has been defined, from years ago. And we know that with increased risk of maternal and neonatal complications, predisposing the infants to developing obesity, diabetes, and even cardiovascular disease in early on in adulthood. And we also know that tight glycemic control to prevent these outcomes is the major focus of antenatal care, right? So we are well aware of all these. And then again, hyperglycemia in pregnancy is associated with a variety of fetal and maternal adverse outcomes and complications, not only in the acute setting, but also in the long run. So with all this background, I want to just remind you that our standard glycemic targets are fasting. The ADA recommendations are one set, but our DIPSI recommendations are clearly what we follow in India and what the Ministry of Health and Family Welfare also suggests are maintaining a fasting blood glucose of less than 90 milligrams per DL and 2 hours postprandial of less than 120 milligrams per DL. With all that, of course, one of the important aspects of managing glycemia in pregnancy is monitoring blood glucose. And without any doubt, SMBG of self-monitoring of blood glucose is the gold standard. However, constant pricking or regular pricking and finger stick method also comes with its own set of cons, and stress, anxiety, panic, hurt, inconvenience, pain, all that comes along with it. And we can see that sometimes patients record them so poorly, and to make sense of SMBG like this without any structure can also be very, very difficult. So today we know that something like CGM or continuous glucose monitoring is actually revolutionizing the diabetes clinical practice, and we must really be ready to adapt this in practice. So here you can see that it's a clear transverse view of the sensor being inserted in the skin. You can see that the glucose sensor from the interstitial fluid will pick up the glucose levels and transmit that, and then we can see those in on the phone itself or on the reader. And that also will come with several other features like the trend arrow, the alarm feature as well, and the entire profile over the said period. So a lot of features come along with it. So we are all familiar again with CGM, but and we know that type 1 diabetes has poor outcomes, but what about type 2 diabetes with pregnancy? And this particular session's focus was on that. With that, let me also remind you that the consensus, the international consensus on time in range, published in 2019 by Tade et al. Uh, Dr. Banchi Sabu sir was also part of this consensus, and they gave us recommendations for different situations, say type 1, type 2 diabetes, then those with older age, or at high risk of hypoglycemia. Again, what targets to be set in that? We have very specific targets for even type 1 diabetes. But for type 2 diabetes and pregnancy and also gestational diabetes, there's really no consensus regarding the same, because we don't have adequate data to show us what is a good target to have. So in absence of that, they have said that we should follow a very strict glycemic control, and we should be in time in range as high as possible without a significant TBR. So again, just to remind you that every 5% TIR matters, because every 5% improvement in TIR is associated with a reduction in the risk of large for gestational age, neonatal hypoglycemia, and also NICU admission. But as far as early onset type 2 diabetes pregnancy goes, really we do not have a clear answer on that. So we don't know, even if we use CGM, we don't really know what are we aiming for. We do feel that maybe those people who use CGM with type 2 diabetes in pregnancy, they probably are doing better than type 1, but we really don't know if they are doing as well as they should. So CGM in type 1, and one of the iconic sort of trials was the concept trial, which clearly showed us that the use of CGM is highly recommended in type 1 because it is associated with improved outcomes, maternal as well as neonatal. And this is a summary of the concept trial. I'm not going through the details. The only reason why I decided to show you this slide is to contrast it with what we know today from type 2. So in concept, the neonatal outcomes include decreased in LGA, decrease in neonatal hypoglycemia, and decrease in NICU admissions. No differences in maternal outcomes were seen. This is by Dennis Faig et al. In Lancet 2017. This was with the use of CGM. So clearly we know that there is benefit of using CGM in type 1 diabetes and pregnancy. Now, which metric is most important? Again, this observational cohort study of 186 pregnancies was again important, but this is with type 1, and you will gradually know why I'm walking you through all this data. Here, there were 92 people with real-time CGM, the Dexcom CGM, and 94 of this cohort used the intermittently viewed CGM, which is the Freestyle Libre, and the data was analyzed. Okay, the women were also managed 2 to 4 weekly and advised to do SMBG at least twice a day. HbA1c was measured 4 to 8 weeks at intervals, and CGM metrics were calculated. The primary outcome was LGA, a neonatal composite outcome consisting of macrosomia, shoulder dystocia, neonatal hypoglycemia, and admission to NICU. The variables associated with LGA were studied at length, and then in the first trimester, it turns out that HbA1c was a very significant uh, marker or variable which was associated with LGA. If you look at trimester 2, then suddenly the mean glucose appears to be important. That's clinically significant. And then variable in trimester 3, also mean glucose values were very statistically significantly associated with LGA. So the strongest predictor of LGA or large for gestational age in trimester 1 is HbA1c. And the reason why I'm telling you this is so that we can screen our women more effectively. And trimester 2 and trimester 3, the mean sensor glucose was most important. Now, if we look at the CGM metrics and LGA across gestation to look at the association with birth weight, then again, this is type 1, but we'll get some important answers from this. This was a combined data analysis from the concept trial and the Swedish study, where 386 women with type 1 diabetes and their CGM metrics were analyzed, each across each gestational week, and divided by LGA and the normal size infants. And if you review the data carefully, you can see that the mean glucose, again, the red line is where those infants that had LGA, and those are the women who gave birth to infants with LGA, and blue is indicates no LGA. And you can see whether it is mean glucose or it is percentage time in range or TIR, which is an important CGM metric. The separation between the two, that whether you're going to have an LGA complication or not, is as early as the 10th week of gestation. Similarly, even for TAR, you can see that the separation is as early as 10th week. So from this, you can conclude that the differences in glucose levels emerge from the 10th week onwards and are sustained throughout the pregnancy. And achieving mean glucose of less than 7 millimoles per liter is associated with a normal size infant. And early intervention before even 10 weeks of gestation, aiming at least 55 to 60% time in range, and even more than 70%, can reduce the occurrence of LGA. So CGM data will need to be reviewed on a weekly basis. Before 10 weeks, in fact, most maternal glucose levels remain above the target. But the second and third trimesters, you can see that there are only postprandial peaks remaining, and the fasting glucose levels are quite under control. This means that we can target maternal dietary intake and teach them carb counting and taking the insulin dose accordingly. Now coming to the crux of the talk, where a role of CGM in diabetes type 2 and GDM were also reviewed. And there are two major studies where one is a randomized controlled trial published in 2018, where they saw that between CGM and SMBG, there was no significant difference in terms of the primary outcomes. But a systematic review of 14 studies was inconclusive. So with all this confusing data, the verdict is that we definitely need more studies. But let's see what they presented so far. Now, one of the most important studies today in this field of early onset or youth onset type 2 diabetes is the Today study. And that was to assess the pregnancy outcomes in young women with youth onset type 2 diabetes, followed in the treatment options for type 2 diabetes in adolescents and youth study. And they found that from the Today cohort, young women with pre-gestational youth onset diabetes type 2 had very high rates of maternal complications. And these were seemingly coming from significant socio-economic disadvantages. So today, in fact, today's study included 260 pregnancies from in 141 women, and 65% had obstetric or neonatal complications, 25% had a miscarriage or stillbirth, 10% had congenital anomalies, and if they maintained an HbA1c of less than 8%, then the cardiac abnormalities were 5%, and that increased to 20% if the HbA1c was above 8%. So these are some important derivations from the Today study, which was again also corroborated by the National Diabetes Audit from the UK, where they looked at young people with type 2 diabetes, and you can see that the amongst the all the age tertiles that they looked at, 19 to 25 has the highest incidence of type 2 diabetes. So 16% youth onset and 84% young adults are between the age of 19 to 25 years in their life cycle. And 57% of all pregnancies with early onset type 2 diabetes are with type 2 diabetes rather than GDM. The rates of serious outcomes for women with type 2 diabetes and their babies have increased in the last few years, and you can see this very well exemplified in this diagram. Now, the third trimester HbA1c and perinatal death, this was also studied in this particular endeavor, and they found that amongst all the risk factors, HbA1c of 6% and less was the only modifiable risk factor that they found, which was correlating extremely well with perinatal death because of type 2 diabetes. So type 2 diabetes, in fact, is more concerning than type 1 diabetes when it comes to perinatal mortality. Again, this is a large study of pregnancy outcomes of young women with type 2 diabetes, and they looked at more than 5,000 pregnancies with early onset type 2 diabetes, and preterm births, LGA, and neonatal care admissions were lowest when HbA1c was maintained at less than 6.1% in these young women with diabetes. In fact, now coming to specifically use of technology, and one of the important publications in this matter in 2023 was the feasibility and acceptability of intermittently scanned continuous glucose monitoring for women with type 2 diabetes in pregnancy, where they found that the feasibility was all right, even with discontinuation rate of 21%. The sensor use was variable and intermittent, and even there were referrals that were much late than early on, but definitely it was more feasible to use a CGM. And the acceptability as compared to the finger stick testing was very high, and 94% of the women said that they would recommend CGM to others irrespective of the outcomes. But let's look at what CGM use does to the time in range. Does it really improve it or not? So when you compare the CGM metrics in early pregnancy versus late pregnancy, you can see that, 64% in early pregnancy, 68% time in range in late pregnancy. So there's not much that CGM use is doing. In fact, the trimester specific time in range in this second graph also, you can see that the values are pretty similar. They are not very significantly different, which means that CGM is not impacting the time in range. And this again, looking at the National Pregnancy and Diabetes Audit from 2021 to 22, they looked at the CGM use, glycemic control, and pregnancy complications, and they found that CGM use was 47% approximately, and SMBG was 55%, and HbA1c of less than 6.1% in late pregnancy was to be maintained. But with CGM users, they did not find any particular lower rate of preterm birth, LGA, or NICU admission. So guidelines today also endorse that CGM should be used in tandem with HbA1c targets or with SMBG, so that CGM can actually help reduce macrosomia, neonatal hypoglycemia, etc., like it does in type 1 diabetes itself. But it should be used in addition to SMBG. So in summary, CGM is superior to SMBG in type 1 diabetes, but in type 2 diabetes and gestational diabetes, we definitely need more research, and we also need more studies to come out with the correct targets for us to follow. And this is a very good publication that you should go through. This was also shared in the talk, that association of CGM metrics with pregnancy outcomes in patients with pre-existing diabetes, and where they have clearly said that every 5% matters because it does impact neonatal morbidity, LGA, and NICU admissions. Now, moving on to the second talk, I'll go fast because I do have to cover the third talk as well. This was by Dr. Maya J, and she spoke about how the rates of type 2 diabetes and pregnancy have quadrupled in the last 20 years or so, with higher rates accompanying the obesity epidemic. And again, we know that obesity has taken over the world. And again, hyperglycemia and a higher pre-pregnancy BMI do increase the risk of pregnancy and intrapartum complications, as well as long-term metabolic outcomes for both mother as well as child. Besides that, her talk focused on the newer therapies, which is the GLP-1 receptor agonists, again, which have taken the incretin-based drugs, which have taken the world by storm. And in the last 4 years, we have seen this massive surge in the use of GLP-1 receptor agonists in clinical settings. So outside of pregnancy, also we can see that whether it is Wegovy or whether it's Mounjaro, the surge is amazingly high and it's very steep. But again, in the periconceptional period also, in fact, the use of SGLT2 inhibitors has also increased along with GLP-1 receptor agonists. So these are the new kids on the block, and this was a specific talk tailored to look at the use of GLP-1 receptor agonists in the periconceptional period and what impact does it have on the mother as well as on the infant. So established therapeutic options for obesity and diabetes that improve glucose control, weight, and cardiovascular outcomes. Because of these established benefits, there is an upsurge in the use of these newer drugs. So again, it's not very clear how the newly widespread use prior to pregnancy will affect pregnancy as well as postnatal outcomes in exposed mothers and their children. But the dictum was, because we don't know much about the impact in pregnancy, the dictum was to discontinue the GLP-1 receptor agonist use before pregnancy. GLP-1 receptor agonists during organogenesis in animal toxicity studies have been associated with congenital anomalies, growth restriction, and also fetal mortality. Adverse fetal outcomes at doses below the maximum administered in humans has been tested. And currently, the dictum is that at least 8 weeks before pregnancy, we should discontinue these drugs. Recommendations are based on fetal growth, placental development, and maternal health, but we don't know much because as the ratio is not really available. Apparent teratogenesis in animal animal studies may not be a direct effect of the medication, but also may be related to maternal weight loss, is something that has been floating around this particular theory, but we are not completely sure. And as far as congenital malformations in humans are considered, there is a retrospective multinational cohort study which includes 3514865 pregnancies. That's a massive, massive number. In this particular cohort, pre-gestational diabetes affected 1.5% of the pregnancies, and they were treated with anti-diabetic medications up to 30%. And the use of GLP-1 receptor agonist was very much included in this. And 90 days before the LMP to the end of the first trimester was noted as maximum drug exposure, and this was associated with congenital malformations. But it's difficult to tell whether it was due to sulfonylurea use or DPP-4 or GLP-1 receptor agonists or SGLT2 inhibitors. Again, the risk for any and cardiac major congenital malformations in the infants born to women with type 2 diabetes and periconceptional use of the GLP-1 receptor agonists, you can see that the risk does exist. It's minimal, but it does exist. Again, this is an important study because this was the first study to provide data on the safety in human use during the periconceptional period for the for metformin users as well as insulin, and then GLP-1 receptor agonists as well. But you can see that there was no increased risk of major congenital malformations as compared to those who used insulin alone. Now coming to GLP-1 receptor agonist use in early pregnancy and reproductive safety. This was a multinational observational prospective cohort that was presented where the data was collected from the patient and provider initiated reports from 6 teratology centers where there were 168 GLP-1 receptor agonist exposed pregnancies of specifically first trimester and 319 GLP-1 receptor agonist unexposed pregnancies that were compared. 156 of these were with diabetes on some other medication as well for diabetes, and 163 were with overweight, obesity. And they found that there was no particular increase in congenital malformations or even pregnancy loss. However, if you look at this particular table and the last column that I have highlighted for you, you can see that the pregnancy termination was much higher in those women who were GLP-1 receptor agonist exposed as compared to those who had diabetes or those who were overweight and obese. And this was to do with the fact that we do not have much information about these drugs and their periconceptional use. So overall, GLP-1 receptor agonist teratogenicity, we can say that based on the animal toxicity studies, we should discontinue it 8 weeks prior to pregnancy, but more data is clearly required. Data in humans is reassuring, but more studies with larger sample sizes and examining additional pregnancy outcomes are needed to better understand the periconceptional exposure. Now, looking at the periconceptional exposure, there were 2 major retrospective cohorts examined from the prescription records and the ICD codes from the US collaborative network in TriNetX. And one study showed that low risk of gestational diabetes, hypertensive disorders of pregnancy, preterm delivery, and cesarean delivery were observed with GLP-1 receptor agonist exposure 2 years prior to pregnancy. And then another one showed that 1 year prior to pregnancy, exposure to GLP-1 receptor agonist did not find a difference in all-cause mortality or hypertensive disorders of pregnancy. This was a large study, representative data set, However, maybe there was residual confounding and maybe some misclassification as well. So, what do we know about the published studies with about pregnancy outcomes? There's limited observational studies, and the concern regarding residual confounding is still there. So, we need more detailed information to see what happens when they are exposed and when they are not. Now, discontinuation of GLP-1 receptor agonist in real life or outside of pregnancy, we know that that results in rebound weight gain. But it is also important to understand that what happens in pregnancy and a period of a physiologic weight gain itself, what will discontinuation of GLP-1 receptor agonist before do to that? And again, we know gestational weight gain is an independent risk factor for gestational age or even maternal weight of 1 year postpartum or even the infant rapid weight gain in early childhood. All that is very well correlated with gestational weight gain. And animal models do suggest that greater gestational weight gain is associated with preconception exposure to GLP-1 receptor agonists. So again, this was in a massive study. They found this is not published as yet, so I'm just going to go through it very quickly. This was presented by Dr. Maya J, and it's under review at the moment, but this is a beautiful study that they had done. Pre and early pregnancy GLP-1 receptor agonist use and the association with gestational weight gain and birth weight is something they looked into, and a beautiful study. But let me tell you that what the conclusion was, and they found that gestational weight gain is greater in pregnancies with pre and early pregnancy exposure to GLP-1 receptor agonists as compared to those who are not exposed to GLP-1 receptor agonists. There is no difference in the newborn size, but again, they also concluded that long-term data is required to tell us if there should be any pediatric risk from the same. And the last and very quickly from Dr. Wendy Bennett, new approaches to preventing diabetes after gestational diabetes. She covered beautifully what the trends in GDM diagnosis are right now, what is the future risk of type 2 diabetes, and what are the lifestyle, weight loss, pharmacological, and other scalable options or interventions that are actually working. What are the different postpartum care opportunities, and what is the role of the social determinants of health and the research gaps? Again, very quickly, preconception HbA1c, though that was studied in several women, almost from 14,000 women that they looked at, they found that if the pre-pregnancy HbA1c was 5.7 to 6.5, then gestational diabetes after the first birth would be 2.21, an odds ratio of 2.21, which is significantly high. So overall, last few years, rate of GDM has increased in the US particularly, but we know Southeast Asia is leading that. In the US alone, there is a 30% increase, and the greatest driver of gestational diabetes seems to be the pre-pregnancy weight or overweight obesity or BMI. And thus, pregnancy is a stress test for the body. Again, in terms of differential risk of progression to type 2 diabetes, and she presented this data that it seems that coming from the Black racial background, even without BMI adjustment, seems to be one of the determinants of uh, developing type 2 diabetes post GDM in these women. And effective diabetes prevention strategies. There was a systematic review of postpartum lifestyle interventions to prevent diabetes presented, where intensive lifestyle interventions that involved mostly dietary counseling and goal setting. This was 24 studies involving more than 9,017 women, follow-up of almost 19 months. That reduced the overall incidence of diabetes by 19%. and higher the risk for GDM, had the greatest benefit of lifestyle intervention and weight loss. Weight loss of up to 6 pounds was seen between the two groups. So again, from the diabetes prevention trial also, where women had GDM, intensive lifestyle intervention reduced the risk by 35%, and metformin reduced the risk of developing diabetes by 40.4%. Whereas those who did not have GDM, intensive lifestyle intervention and metformin were, not significantly more important. So we must consider this very aggressively for those who have had GDM, and then we want to prevent diabetes in them. Breastfeeding in diabetes prevention is also very important, and she presented data that showed us that if there was exclusive lactation being followed, then the risk of diabetes was considerably lower than others who did not exclusively follow that. And last but not the least, the strongest evidence supports the use of metformin for diabetes in prevention of GDM, but the uptake is very low. And smaller studies have looked at other agents also, but the most important one is metformin. And again, she urged that we cannot use GLP-1 receptor agonists in lactating women, but we must study it further to look at what is actually working and what is not. Besides that, she also emphasized on the role of primary care follow-up, even expansion of the insurance coverage, and then interventions to address food insecurity in the postpartum period to reduce the diabetes risk in GDM women, and testing for GLP-1 and SGLT2 inhibitor medications after delivery, after completion of breastfeeding, is something we should strongly consider to help these women lose weight and prevent diabetes. So this is all from me. Thank you again. It was a long update, but thank you very much for your patient hearing. And I'm very thankful to Diabetes India team.
Thank you, Dr. Purvi, for a excellent coverage of for the snapshots of the ADA, and a topic very well covered. Can we take the question and answer after Dr. Anuj Maheshwari sir's talk?
Amit, I think we can take her because
Right. Okay.
here already it's a half an hour late.
Okay.
So
Okay.
we can take one or two talk because she is
So,
from.
so RX team, can you check? Are there any questions in the chat box?
There's no answer.
No. Okay.
So one of the question to Purvi, if you, because some of now Indian patients are also exposed with GLP-1, and you had shown a data that uses of GLP-1 before pregnancy up to 2 years had not shown any. But some of the patients who are already on GLP-1 and if they become pregnant, is there any data that someone in her in first few weeks till they diagnose, till they confirm with the pregnancy, is there any side effect? If someone is on GLP-1, there are a lot of obese young female, or either for type 2 diabetes or for obesity. And I'm sure in coming years there will be many more such. So is there any reassuring data that there will not be any problem with the GLP-1?
So you're absolutely right. It appears that there may not be any immediate need for, termination of pregnancy. Also, we can definitely continue to monitor these pregnancies. And there's a colloquial term called Ozempic babies also for the same. To those infants that are born to women exposed to the GLP-1 receptor agonists. However, we do not have definitive data to say that it is not teratogenic or it will not have any impact on the maternal outcome. In fact, those women who had discontinued the GLP-1 receptor agonist did have higher gestational weight gain, which in itself is a driver of not only GDM but also for impacting the infants negatively. So I think it's a double-edged sword and should be tackled with carefully. We definitely need more data. Maybe does not have a direct impact or causing teratogenicity, because the doses used in humans are far lower than the ones that were used in the animal teratogenicity studies.
Amit, you have any question?
No, sir. Thank you, Dr. Purvi, for a wonderful presentation again and very comprehensively covering this very important update from the ADA. And we will not block you from enjoying your dinner, so you can have that. And meanwhile, we will proceed to the next talk. And for that, we have Dr. Anuj Maheshwari with us. Can we have the CV slide of Dr. Anuj Maheshwari? So, Dr.
Thank you
Anuj
again. It's indeed an honor to have to share this with Anuj Maheshwari. So, thank you so much.
Thank you. And Dr. Anuj Maheshwari, welcome, Dr. Anuj Maheshwari. Dr. Anuj Maheshwari is the president-elect of the RSSDI, and he is the past vice president of the RSSDI and past governor of the American College of Physicians India chapter. A very well-known researcher, clinician, and known for his many path-breaking initiatives in the field of diabetes as well as the hypertension. So, over to you, sir, and you will be bringing us some of the highlights from the ADA. And as you know, this program is specially designed so that those faculties from India who have attended the ADA and presented there, they are part of this program, and they bring their real-time learning from the ADA to the benefit of our audiences here. So welcome, Anuj sir.
Welcome, Anuj. Thank you for joining. And please unmute and please share the slides. Thank you.
Thank you, Dr. Bansi. Thank you, Amit. And thank you all team Diabetes India for giving me this opportunity. And I share my I have been today asked to speak about the standards of care in diabetes 2025. Of course, this is a very vast and very elaborated topic, but I shall try to make it more and more useful part to be bringing it, although it is really very difficult to find the useful part, but somehow we can select the part which are more of the importance for the practitioners and of course which are newly added to this standards of care in 2025. So looking forward for your attention in next 20 minutes. So as we all understand very well, diagnosis of the diabetes is the most important part, and it has been said by ADA that diagnosis diabetes based on the HbA1c or plasma glucose criteria is still existing as a method of diagnosis. Plasma glucose criteria include either the fasting plasma glucose or 2-hour plasma glucose during a 75-gram oral glucose tolerance test or random glucose accompanied by classic hyperglycemic symptom crisis. If anybody is having 100 or more with classic hyperglycemic symptom or with hyperglycemic crisis, we can take it as a diabetes diagnosis even without confirming. Use of HbA1c for screening and diagnosis of diabetes is recommended by ADA. Although in Indian perspective, there are certain riders for this method of screening and diagnosis of the diabetes, like in conditions associated with an altered relationship between HbA1c and glycemia, like many conditions which are associated with hemoglobin variant, anemia, pregnancy, especially in the second and third trimester, and postpartum period when HbA1c and its accuracy becomes questionable. Glucose 6 phosphate dehydrogenase deficiency, G6PD deficiency, HIV, hemodialysis, sometimes recent blood loss or some transfusion has occurred by the patient and hemolysis, therapy, plasma glucose criteria. These are the things in which the HbA1c becomes controversial as far as the diagnosis and screening of the diabetes is concerned. Criteria which are defining the pre-diabetes in the non-pregnant individual, again, this is a very important part in the Indian perspective because India is a country where a big number of the pre-diabetes individuals are there, and this is actually our opportunity to bring them back to the non-diabetic status if we can really handle these pre-diabetes patients with utmost care and give them opportunity for the reversal, like HbA1c, which is ranging between 5.7 to 6.4, fasting plasma glucose 100 to 105, 125, and 2-hour post-glucose 75 gram ODT between 140 to 199 is considered pre-diabetes. Let's talk about the classification of the diabetes given by the ADA. Type 1 diabetes, we all understand, because of the autoimmune beta cell destruction, which may lead to the absolute insulin deficiency in autoimmune diabetes in adults. Type 2 diabetes, which is the most common variety of the diabetes arising out of the insulin resistance, non-autoimmune progressive loss of the adequate beta cell destruction, frequently on the background of the insulin resistance. The specific types of the diabetes are certain like monogenic diabetes, exocrine pancreas-related diabetes or pancreatogenic diabetes, and sometimes certain drug-induced or clinical-induced diabetes. Last but not the least, the most important, gestational diabetes, for which my previous speaker, Dr. Purmeet Chawla, has given a very nice and very elaborated account of the gestational diabetes. So if we talk about the type 1 diabetes, in the pre-symptomatic period, if we really try to screen, which is really very difficult because before symptoms are arising, it's difficult to identify the patients of the type 1 diabetes. But this can only be done by detection of the autoantibodies to the insulin, stomach acid decarboxylase or GAD antibodies, islet antigen 2, or zinc transporters 8 antibody. Autoantibody-based screening for the pre-symptomatic type 1 diabetes should be offered to those who are having a strong family history of the type 1 diabetes or otherwise known elevated genetic risk. The people whose kids are being suspected to have the type 1 diabetes, we can try with screening of these methods in the pre-symptomatic stage also. Standardized islet autoantibody tests are recommended for classification of the diabetes in adults who have phenotypic risk factors that overlap with those for the type 1 diabetes. For example, younger age of the diagnosis, unintentional weight loss is happening from someone, or if a kid is presenting with a ketoacidosis recurrently or short time to the insulin free. So if we really suspecting anyone with the type 1 diabetes, of course the test islet and autoantibodies gives us an idea about if it is positive. Of course the patient can be labeled as a type 1 diabetes. But in case if it is not positive, it's negative, then we should look for the age of the patient less than 35 years. Then we should look for the possibility of the monogenic diabetes. If it is monogenic diabetes, then of course we should go for the C-peptide, and if it is more than 200, then we can go for the genetic testing for the monogenic diabetes wherever it would be available. If it is less than 200, then we can consider it again type 1 diabetes. In a situation where the monogenic diabetes features are not there, then again we should look for the type 1 diabetes or type 2 diabetes, depending upon the underlying clinical features, underlying investigation, which could be there positive for the insulin resistance or positive for the autoimmune disease. If the age is more than 35 years, the chances are more for the type 2 diabetes. Classification may be a bit unclear. It may clinical decision as to how person with diabetes should be treated. Trial of the non-insulin therapy to be given if the patient responds, then we can label it as type 2 diabetes. We can also consider C-peptide test after 3 years or more than 3 years of the duration. And if it is really indeterminate, consider repeat C-peptide after 5 years. But if it is than 600, then type 2 diabetes can be labeled. Pharmacological interventions to delay symptomatic type 1 diabetes. This is the innovative and this is really a new thing which must be known to our practitioners. If we can really suspect anyone, if somebody is having family history of type 1 diabetes as well as some genetic predilection which are leading towards the occurrence of the type 1 diabetes, teplizumab infusion can delay the onset of the symptomatic type 1 diabetes if we are sure that it could be because of the autoimmune degeneration of the pancreatic tissues. And selected individuals, those who are of the age 80 years or more than 80 years with stage 2 type 1 diabetes, they can be the candidate for this therapeutic option. pre-diabetes and type 2 diabetes. Of course, as I already said, the pre-diabetes is the window of opportunity for the reversal of the diabetes, take the back towards normalcy. Screening for the risk of the pre-diabetes and type 2 diabetes with an assessment of the risk factors for validated risk calculator should be done in asymptomatic individuals. For all other people, screening should begin at age 35 years, but in case of the pre-diabetes or type 2 diabetes, asymptomatic people should be considered in adults of any age with overweight or obesity who have one or more risk factors. In people without pre-diabetes or diabetes, after screening, repeat screening recommended at a minimum of 3 years interval is reasonable sooner with symptoms with change in risk-based screening for the pre-diabetes or type 2 diabetes should be considered after the onset of the puberty or after 10 years of age, whichever occurs early. In children and adolescents with overweight, BMI having more than 85th of the percentile, or obesity having the 95th of the percentile, and who have one or more risk factors for the diabetes. Consider screening people for pre-diabetes or diabetes if they are on the certain medications like glucocorticoid, statin, thiazide diuretic, HIV medication, second generation antipsychotic medication, and annually thereafter. People with HIV should be screened for diabetes and pre-diabetes with an fasting plasma test before starting antiretroviral therapy. At the time of the switching antiretroviral therapy and 3 to 6 months after starting or switching antiretroviral therapy. If initial screening results are normal, fasting plasma should be checked annually. So these are the three stages of the type 1 diabetes in which we can divide these three stages on the basis of the characteristics like autoimmunity is present but no patient is still normoglycemic and symptoms are not there. We can take it at stage 1 of the type 1 diabetes. Stage 2 type 1 diabetes is when the autoimmunity is there but dysglycemia has also started although there is no symptom. And stage 3 is there when all the three things are there. Patient is having over hyperglycemia, autoimmunity evidences are there and symptomatic is also. So these are the three stages, and if we are finding the patient with stage 2 onward, then we can use or we can try that. Now, this is a wonderful score which has been provided by the ADA for knowing whether a person is having high risk for the type 2 diabetes. If a person is found to be score 5 or more, then he can be considered high risk for the type 2 diabetes. Now the question arises, if we find anybody for the high risk type 2 diabetes, how can we lower it down? The good news is one can manage his risk for the type 2 diabetes. A small steps makes a big difference in helping one in a longer, healthier life. And what could be that? Obviously, the lifestyle modification could be the thing which can really look for a person for the reversal. Monogenic diabetes. Diabetes diagnosed within the first 6 months of the life. Diabetes without typical features of the type 1 or type 2 diabetes. Negative diabetes associated autoantibodies or there is no obesity and it's lacking and other metabolic features, especially strong family history of the diabetes. Stable, mild, fasting hyperglycemia. Stable HbA1c between 5.6 to 7.6, not very high, especially if no obesity. We can think about the monogenic diabetes. Let's talk about the gestational diabetes, although Dr. Chawla has very nicely covered this topic in very elaborated manner. I'm not going to talk much about the gestational diabetes, but few important things must be told that in individuals who are planning pregnancy, we must screen those who are on the higher risk. Consider their testing all individuals of the childbearing potential for undiagnosed diabetes or diabetes. But always remember this direction is from the ADA, which may not be exactly applicable for the Indian population. In Indian population, we consider that each and every woman who is going for the childbirth should be screened for the gestational diabetes. Each and every woman which is planning for the pregnancy, before entering into the pregnancy, she should be screened for the hyperglycemia and Even pre-diabetes, if she is found to have some indication, she should be watched carefully in the execution of the pregnancy for the gestational time. Before 15 weeks of the gestation, test individual with the risk factors, those who are having the more risk factors, and we should consider testing of all the individuals in Indian perspective for undiagnosed diabetes at the first prenatal visit to standard diagnostic criteria, if not screened for the preconception means before 15 weeks of the gestation, abnormal glucose metabolism should be screened to identify individuals who are at high risk of the adverse pregnancy and neonatal outcome are more likely to need insulin and are at high risk of GDM. Screen for the early abnormal glucose metabolism is glycemia using fasting plasma glucose 105 or HbA1c 5.96 is an indication that this person may be needing insulin or therapeutic options to be added in the gestational diabetes period after 8 weeks. Pharmacological interventions to delay type 2 diabetes. As we found that teplizumab, similarly, we can also have something to delay type 2 diabetes also, especially in the pre-diabetes, and that is metformin, which could be used in the period of the pre-diabetes in addition to the lifestyle modification. And especially when we are using the metformin, must not forget that metformin causes the vitamin B12 deficiency. Periodic assessment of the vitamin B12 in metformin treated individuals, especially if it is being started in the pre-diabetes, especially in those with anemia and peripheral neuropathy, which is very commonly seen in our country. Vascular disease and mortality and its prevention. Pre-diabetes is associated with heightened cardiovascular. Many people, those who start the endothelial dysfunction 15 years before the development of the diabetes or development of the diagnosis of the diabetes, and in fact, in pre-diabetes, they invite the heart attack and cardiovascular adverse. Therefore, screening for and treatment for a modifiable risk factor for cardiovascular disease are suggested in pre-diabetes. Statin therapy is recommended even in pre-diabetes, especially in the people at high risk of developing diabetes. In such individuals, glucose status should be monitored regularly and diabetes prevention approaches reinforced. It is not recommended that statin be avoided or discontinued for this adverse effect. In people with a history of stroke and evidence of stroke and diabetes, pioglitazone may be considered for the risk of the stroke or MI. However, this benefit needs to be balanced with the increased risk of the weight gain, edema, and fracture. Lower doses may mitigate the risk of the adverse effect, but may be less effective. Person-centered care goals are important in the ADA perspective. Adults with the overweight or obesity at high risk of the type 2 diabetes. Care goals should include weight loss and maintenance, minimizing the progression of the hyperglycemia, and attention to cardiovascular risk. Pharmacotherapy should be considered to support person-centered care goals. For example, if patient is overweight, we should look for the pharmacotherapy, which is having the weight loss potential, help in the weight management, minimizing the progression of the hyperglycemia, as well as cardiovascular risk reduction. More intensive preventive approaches should be considered in individuals who are at particularly high risk of the progression of diabetes, including individuals who are having the BMI 35 or than that. Those at higher glucose level, fasting plasma glucose ranging 110 to 125. Post 2 hours post challenge glucose is ranging between 170 and 99, and HbA1c 6 or more than that, and individual history of the GDM, they all should be kept for the more intensive preventive approaches. Comprehensive medical evaluation includes for the which should be done at the first initial visit to follow up as appropriate to confirm the diagnosis and classify diabetes, assess the glycemic status, and we look for the previous treatment, evaluate for the diabetes complications, potential comorbid conditions, overall health status, identify care partners and support system, assess the social determinants of the health and structural barriers to optimal health and health care, review risk factors management in the persons with established diabetes, Begin engagement with the persons with diabetes, creation of a care management plan, including initial course of care. Develop a plan for the care. Ongoing management should be guided by the assessment of overall health and functional status, diabetes, complications, cardiovascular risk, hypoglycemia risk, and shared decision making. Therapeutic immunization is very important part of the diabetes treatment, which is more focused by the ADA standards of care. Provide routinely recommended vaccination, not only for children, but also and especially focused towards the adults with diabetes, as indicated by their age. What are those? Obviously, COVID-19 vaccination should be received by all people 6 months of the age and older. Hepatitis B, adults with the diabetes aged less than 60 years, for adults aged 60 years or more than that. Hepatitis B vaccine must be administered at the discretion of the treating clinician based on the person's likelihood of acquiring hepatitis B infection. Influenza, all people with diabetes. Pneumonia, Pneumovax vaccine, 19 to 64 years of the age vaccinated with Pneumovax, all patients with the diabetes should be receiving. PCV or PCV15, adults 19 to 64 the age having an immunocompromising condition, cochlear implant or cerebrospinal fluid, adults 19 to 64 the age with immunocompetent should be receiving the vaccination. RSV, older adults more than 60 years of the age, tetanus, diphtheria, all adults, whatever the age, pregnant individuals should have an extra dose of the tetanus and diphtheria pertussis, and booster should be every 10 years. Herpes zoster, for more than 50 years of the age, 2 doses of the Shingrix when if previously vaccinated. And these are the vaccination schedules which must be followed and must be offered to each and every patient with diabetes. Autoimmune diseases must be explored in the patient of the type 1 diabetes, especially autoimmune thyroid disease, and uh, uh, um, uh, some of the diseases which are involving the GI symptoms like celiac disease. Bone health. We must assess the fracture risk in older adults with diabetes as a part of routine care in diabetes clinical practice according to the risk factor. Monitor bone mineral density using DEXA in older adults with diabetes aged more than 65 years and younger individuals with diabetes and multiple risk factors have been seen here. Consider a potential adverse impact of the skeletal health when selecting pharmacological options for post-level with diabetes. Avoiding medications with a known association with higher fracture risk like thiazolidine sulfonide should be recommended and they should be avoided, particularly for those at elevated risk of the fractures. Cognitive impairment and dementia, the presence of cognitive impairment and dementia, which is very commonly seen in the current perspective of diabetes treatment and increasing life expectancy of various individuals and various populations, even living with the diabetes, they are having these kinds of the symptoms. And if they are having the diabetes treatment plan should be simplified as much as possible and tailored to minimize the risk of the crisis. Dental care. People with diabetes should be referred for a dental examination at least once per year. Coordinate efforts between the medical and dental teams to appropriately adjust glucose lowering medication and treatment plan prior to and the post-dental procedure. Metabolic associated steatotic liver disease, MASLD, and steatohepatitis screening should be done to all the patients those who are having pre-diabetes, obesity, having the cardiometabolic risk factor, as well as those who are having a overweight and may be having a possibility of ending with MASLD. They should be screened with the FIB4 fibrosis 4 index derived from the age, SGBT, SGOT, and platelets. And even if they have normal liver enzyme, it should be done. Adults with the diabetes or pre-diabetes with persistently elevated plasma aminotransferase level for more than 6 months and low should be evaluated for other causes of liver disease. These people, those who are having the type 2 diabetes or pre-diabetes with before 1.3 or more than that should have additional risk stratification by liver stiffness measurement with transient elastography, or if it is not available, then we should look for the enhanced liver fibrosis test. Prefer adults with the type 2 diabetes or pre-diabetes and higher risk for the significant liver fibrosis, liver stiffness measurement, or ELF to a gastroenterologist or hepatologist for the evaluation and management. So as we discussed it, type 2 diabetes, pre-diabetes, obesity, having the FIB4 1.3 or more than that, then should look for the high risk of the future cirrhosis. LSM is 8 or more than 8. Then in that condition, we should look for the reason underlying for the NAFLD or NASH kind of the situation. If it is not there, then we can continue managing as a primary care by the interprofessional team, repeating the FIB4 every 1 to 2 years. So similarly, the therapeutic options should also be chosen in such kind of a patient. Those who are having type 2 diabetes and biopsy-proven MASH, or those at high risk for the liver fibrosis, pioglitazone, GLP-1 receptor agonist, or a dual GIP or GLP-1 RA is preferred for the glycemic management because of the potential beneficial effects on MASH. Recently, resmetirom has also got the approval of the US FDA, and now it is also included in the ADA flowchart. Combination therapy with the pioglitazone plus GLP-1 receptor agonist can be considered for the treatment of the hyperglycemia in adults with type 2 diabetes with biopsy-proven MASH, or those at high risk of the liver fibrosis because of the potential beneficial effect on the metabolic steatohepatitis. Metabolic steatohepatitis is seen in patients those who are on the increased cardiovascular risk. Comprehensive management of the cardiovascular risk is recommended with the statin. Consider metabolic surgery in appropriate candidate as an option to treat MASH in adults with type 2 diabetes and to improve the cardiovascular outcome. Metabolic surgery should be used with caution in adults with type 2 diabetes with compensated cirrhosis from MSLD and is not recommended in decompensation. Patient with a metabolic dysfunction associated with steatohepatitis or MSLD has got a specific treatment algorithm to be used with the GLP-1 receptor agonist, dual GIP and GLP-1 RA. If they are having diabetes, then pioglitazone and SGLT are to be added. And if they are having really the MASH, of course, the resmetirom can be the choice of therapy because there is no any other therapy which is recommended for the MASH treatment. Diabetes self-management, education, and DSMES. All people with diabetes should be advised to participate in developmentally and culturally appropriate diabetes self-management, education, and support to facilitate informed decision-making, self-care behavior, problem-solving, and active collaboration with the healthcare team. Medical nutrition therapy is again a very important part of the diabetes management, and ADA has been very peculiar and very conspicuously they are saying that an individualized medical nutrition therapy program needed to achieve treatment provided by a registered dietitian nutritionist, preferably one who has the comprehensive knowledge and experience in diabetes care, is recommended for all with type 1 or type 2 diabetes, pre-diabetes, and gestational diabetes. Because diabetic medical nutrition therapy can result in cost saving and improve cardiometabolic outcome, medical nutrition therapy should be adequately reimbursed by the insurance. Counsel against the beta carotene supplementation, as there is evidence to harm for a certain individual and it confers no benefit. So this is the change the previous trend. Medical nutrition therapy, if we talk about for the pre-diabetes and diabetes, it is recommended to plan the meal with the nutrient quality, total calories, metabolic mind. Eating pattern should emphasize key nutrition principles, non-starchy vegetables, like lean proteins, whole grains, nuts and seeds, low-fat dairy, and non-dairy alternatives. Consider reducing overall carbohydrate. Educate people with diabetes about the signs and self-management of the delayed hypoglycemia after drinking alcohol, especially when using insulin. Religious fasting and intermittent fasting has also been made compared, and the difference between has been found out that fixed duration of the timing of the religious fasting with high level of the intrinsic motivation, risk of hyperglycemia, and at the end of the fasting hours with or without ketones. Dehydration is possibility. While the intermittent fasting is quite scientifically designed, flexible duration and timing, varying levels of the intrinsic and extrinsic hyperglycemia is unlikely is health related. Physical activity is an important part of the treatment of the diabetes. Smoking cessation, tobacco, e-cigarette, and cannabis should be avoided. Psychosocial care is very important. Diabetes distress has been recently introduced in the diabetes management protocol, and this should be handled by the diabetes caregiver, especially once a person is developing diabetes and whole family is in the distress at the time. Anxiety, depression is to be handled, which is arising out of the diagnosis of the diabetes. Disordered eating behavior many a times is the reason for the diabetes and the hyperglycemia, which is to be separately handled with the help of psychotherapy. Serious mental illness, cognitive capacity, and impairment are the things which to be handled in the patients with the diabetes the utmost care. If cognitive capacity changes or appears to be suboptimal for decision making and behavioral self-management, referral for a formal assessment should be considered. Sleep health is another very important thing. If it is not good, then obviously diabetes control with health and hyperglycemia and hypertension, and especially the insulin resistance related problem becomes poor. So here we can also decide if a person is having a good health, good body activity, low treatment risk, and can take more of the burdens and keeping that HbA1c at the lowest possible gives a good stringent and favorable for the uh, complications free life in the future. But in condition when the patient is debilitated, end of the life stage, or maybe having in the elderly age, then A1C goals should be designed as per the capability of an individual to handle. Cardiovascular risk disease and type 2 diabetes, as outlined in more detail, pharmacological approaches to the glycemic treatment, cardiovascular disease and risk management, the cardiovascular benefits, GLP-1 are not contingent upon disease. Therefore, initiation can be considered type 2 diabetes and CVD independent of the current A1C goal or benefit. If already on the dual therapy or multiple therapy, then not on the SGLT2 or SGLT1 are consider switching to these therapies. Introduce SGLT2 inhibitors or GLP-1 receptor agonist in people, CVD that A1C for cardiovascular benefit independent of the baseline A1C or individual A1C. Blood glucose monitoring is an important part not only for the type 1 diabetes, not only for who are on the insulin, but also those who are not using the insulin. They are using the blood monitoring. They can keep their HbA1c at the lower level much easier without hypoglycemia and in least amount of the medication. Continuous glucose monitoring is an extended version of the blood glucose monitoring, which can be used without picking multiple times and also helps the individual keeping in majority of the day time in range, or whenever he is in the time above range, he can be home to this device and it can be controlled and can be taken the rescue measure immediately in the same day also. Insulin delivery can be easier if we can use the CSII continuous insulin delivery system, which should have the continued access across the third-party players. Digital health technology is another very important part, which the combining the technology made with CDM, made with pump, or made with other diabetes operator with online or virtual coaching to improve the glycemic outcomes in diabetes or pre-diabetes. End of life care is another very important part of the diabetes management when palliative care is needed in older adult diabetes. Healthcare professionals should initiate conversation with people with diabetes and their care partner regarding the course and intensity of care. Strict glucose and blood pressure management are not necessary, and simplification of the medication plans can be considered. Similarly, the intensity of the lipid management can be relaxed and withdrawals of the lipid may be appropriate. Prioritize the overall comfort, prevention of the distressing symptoms, and preservation of the quality of life and dignity as primary goals for diabetes management at the end of life. To select diabetes advocacy statements are important because diabetes advocacy is the most important part, which may not be forgotten by any of the person who is practicing diabetes. Diabetes care in the school setting, diabetes care while driving diabetes management in the detention facilities, care of the young children with diabetes in the child care and community setting, insulin access and affordable cost, and diabetes with employment. A lot of employments are there where the person having diabetes are not kept engaged, and many a time, if any employee develops diabetes, they are removed from the job. So these are the things which should be advocated well so that these things may not happen in our society. Thank you very much for the kind listening.
Thank you, Anup sir. It was really a very, very comprehensive summary of ADA standard of care. And we were just discussing at the beginning of the session that now we have standard of care with us. And to implement this standard of care in a clinical practice or in a clinical setting is really a tough task. So, we saw that one of the keynote address at the ADA was how to translate the standard of practice into standard of care into standard of practice. So you are the incoming president of the RSSDI. So what is your thought on that, sir? How can we do that?
First, I would say that these are the snapshots of the ADA. So many of the things which are given by the ADA should be required to be translated in the Indian perspective, because Indian perspective are very much different in multiple. So first, I would like to bring out the Indian standards of care for the diabetes management, like the ADA standards of care are already there. Of course, you may say that we are already having the guidelines, but guidelines and standards of care are little different. Guidelines are that which suggest what you need to do. The standards of care is the highest level of the care where you can reach with the maximum of your thrust or by maximum of your effort. So standards of care is the thing which is the ultimate for the patient's benefit, where we can reach that. Can be easily translated. It's not very much difficult. The most important thing again is the awareness and education, especially that education among the public is the most important. Many of the times we doctors also remain quite reluctant for implementing these things which are being told. Even we are telling it here, but how many of the patients of us are really following these kinds of the standards of care? Very difficult to decide and very difficult to reach out to all of them. So translation is possible, but we have to do a strong efforts for it.
Anuj very rightly said, and I really idea of, not the guideline, it should be the standard of care. And our standard of care should not be less than any other developed countries, and I fully agree with that. And that should be our standard of care. And you had taken all the important points, which I really liked it here. Even you talked about the dental care, that once in a year, which is American Diabetic Association as a standard of care, but which is recommended by them since long, but nobody practiced. As you were the professor of dental medical college and now with the medical school also, you must be emphasizing the importance of dental care, and that what same me and Amit had done in Diabetes India, a very special interest group has been created in Diabetes India. We are going to have one more online webinar only on that, because it's very important aspect which is completely neglected, nor by the primary care physician, even dentists themselves, even the oral surgeon also. They don't also ask the people to go for a sugar checkup regularly. So fully, and few of the important things which I could see in the guideline, even medical nutrition therapy, they have written that it should be reimbursed. That should be the standard of care. The replacement therapy. Yes, it is with the evidence E, because you cannot make the evidence A that if it is reimbursed, probably the things will be better, or if person has to buy on their own, things may be different. So they had put the evidence E. But I can see that ADA people really work so hard that each and every, minutely, if you see, line by line, everything is written with a very highest standard of science and evidence based. And we should come out of an Indian standard of care. The only challenge in India that to create that standard of care, we don't have the Indian evidence. We have to depend on the evidence which has been generated by the Western world. We have more of a real world data or something like a epidemiological, we may show some better data, but otherwise we don't have our own scientific evidence to show. But I endorse your point as a president-elect of RSSDI to come out with the Indian standards of care will be really a great move for improving care for diabetic patients in India. I once again thank you from Diabetes India. It was a wonderful talk. I really enjoyed it. Amit, any other question which is there in the chat box, or you want to make any other comment?
Sir, we don't have a question in the chat box, but I think if we go and start asking question on the standard of care, then we can have this webinar continue for 2 days.
I know. Fully agree. And we already started with the discussion that, it is not executed by primary care physician. At that time, Anuj was not there. So Amit and started with that talk. This year, it was not just the guideline to be released. It is to be practiced. And that's what very important. So I'm sure in coming years in India, we will work more for practicing the guideline rather than creating a guideline. That is more important. People should use the guideline in their day-to-day clinical practice to improve the care for patients with diabetes. Thank you, Amit.
So, sir, so it is day 5. So maybe the concluding remark may come from you. And
No, you finally first get there. So first of all, thanks to Amit. That's very important. That he is the one who is behind the scene, asked me to create we should have a snapshots of ADA and to get the people who are right there, who were there in the meeting. And we are really very proud of Amit. He being as a joint secretary of Diabetes India and executive committee of Amit, as RSSDI, he was invited as one of the invited speaker. Even though there were many other papers and oral paper and presentations from India, but we are really proud that he was there. And it's very important symposia where he was there as a prevention symposia. We are thanking ADA directly. We don't have for this particular snapshots any collaboration, but because so much science is discussed in ADA, we could not stop ourselves that we should have some snapshots from that. And we should discuss all those. And I'm sure thousands of the doctors across the country really enjoyed it. They loved it. We got the feedback from the industry as well as from the audience who were there. Every day, more than 2,000 doctors were registered for the meeting, and 1,000 plus doctors were listening. May not be listening all three talk or all the discussion, but to start with, it comes with 500, 700, they goes back and come back. So we are really very happy that Diabetes India could do it, and thanking RX event and all our 5 partners of industry who were there to help us. But biggest thank is to all the faculty, because they were not provided any slides, any scientific supports. They have done on their own, whatever they listen, whatever photograph is they have taken, they compiled it and they had made it in a scientific talk for 20 or 15 minutes, and they have delivered the best of ADA, whatever they learned. So we are really very much thankful and grateful to all the faculty member, all the chairpersons. And once again, thank you to SR Arvind, President, Dr. Sanjay Reddy, Treasurer, and Dr. Amit Gupta, Joint Secretary, for this wonderful snapshots of ADA. To all of you. Thank you very much once again. Good night.
Thank you very much, sir. One more thing you can invite for the IDF and the Southeast Asia and the ADA program coming in next few days.
So, that's what Southeast Asia as a chair elect and a chairperson as a chair for IDF Southeast Asia. I thought that we should do it for Southeast Asia. I don't know how many people will be there from Sri Lanka and Bangladesh for ADA meeting, but to whomsoever I was knowing, I tried to invite them also for that meeting. And then again, same I'm doing with Diabetes Asia as a vice president. So we will do 2 days webinar for that also with some panel discussion. I'm sure all those who will be registered for those meetings will also enjoy, because topics are completely different. Here we try some different topic, and the topics in Southeast Asia and for DSG topics are different. And I can invite all of you for our RSSDI national meeting at Kochi and Diabetes India national meeting, which we are doing in FAB at Hyderabad. And definitely as a Southeast Asia chair, I can invite all of you for Nepal meeting, that is IDF Southeast Asia Congress, which is in month of November.
Great. Thank you. I join your voice.
Thank you, sir.
Thank you, Anuj sir. Thank you, Vansi sir. And thank you all the participants for viewing this program. We hope to see you soon. And thank you. Thank you very much. Good night.
Bye. Good night.
Recording stopped.